Okie doke. All right. My name is Reagan. Welcome to our 8th virtual shadowing session. We're super excited that you are all here. Tonight we have a wonderful guest speaker. Her name is Dr. Jody Jones. But before we get going, I'm going to first introduce our team. So there's me, Reagan Rosenberger. We have Cheyenne. We have Taylor, Elena, Rachel, Ani, and Miriam. And then, of course, we have Dr. Raymond Fowler, too. So on the next slide, we have our upcoming sessions. So July 21st is today. We're talking about ultrasound. July 28th, we have specialty spotlight with some physician assistants. They're going to be talking about primary care and family medicine. And then August 4th, we're going to be doing diversity in medicine. And then August 11th, we have pediatric medicine. Okay, next slide. And then so as usual, we're going to have 2 Q&A panels, one kind of in the middle and then one at the very end. So go ahead and put all your questions in the chat and our team is going to be sorting through them so that we can try to get to as many as possible. And then just some other announcements, please make sure you are muted so that we can be as efficient as possible. And the quiz is going to be a little different tonight. So we'll put it up a little bit later. So we'll put that up on our Instagram and we'll put it on our website and we'll hopefully give you more information in the YouTube as well. So whenever you're ready, Dr. Jones.
Jody, before you start, let me, and Reagan, if you'd mute everybody and then I will unmute and Dr. Jones will unmute also. Welcome, everybody. It's so nice to have you here. This is a wonderful experience for us, the working group of the virtual shadowing program. This is our 8th session. We have almost 10,000 people worldwide who've signed up, representing over 500 universities. There was clearly a need to have something like this that we can share with you, contact with physicians live, so you can see new concepts, old concepts, anatomy, physiology, and so forth, that will let you think about and decide, what are you getting into? Do you want a career in medicine? Is this the right thing for you? And what may your path be? Tonight, it is my absolute honor to introduce one of my closest friends and someone who I absolutely adore. She is a wonderful physician. We worked back to back on 2 shifts this weekend at Parkland Memorial Hospital Emergency Department, the busiest emergency department in the United States, where we are trying to dodge COVID all the time. Jody is a fellow in the American College of Emergency Physicians, and she is a master ultrasonographer. I have learned so much from Jody. She is the program director and medical director for ultrasound for the Department of Emergency Medicine at the University of Texas Southwestern. I can't say enough wonderful about this master clinician and master ultrasonographer. So everyone in chat, please say, welcome, Dr. Jones. I want to see 1,000 of you pop through there very quickly in chat. And there we go. We're going to have 1,000 people say, welcome, Dr. Jones. That's wonderful. Jody, it's our deep pleasure for 1,000 people online and however many are out in YouTube land to welcome you to the virtual shadowing program. So thank you for coming and please take it away.
Well, thank you very much. So I'm going to start with just a little bit about me, what I do, and how medicine will be when you guys get here. So a little bit about me. I am an immigrant. I'm not from this country, obviously, originally. I was born in Jamaica and my family moved when I was very young here to the United States. I grew up in Atlanta, and when I was done with high school, I wanted nothing more than to get out of the state of Georgia, much to Dr. Fowler's dismay, and go away from my parents. So the question that we always first ask is, why medicine? What made me decide medicine? I was that kid that always knew what they wanted to be. So when you asked me when I was 5 what I wanted to be, it was doctor. When you asked me when I was 10, it was doctor. When you asked me when I was 15, it was the exact same answer. And I don't have a really good reason for you. Neither of my parents are in medicine. My mom was an interior decorator. My dad was an electrical engineer. They're both retired now. I have an uncle who's in medicine, but I'm not super close to him. So I didn't really have much medical background as an exposure, but I just knew that's what I always wanted to do. And to get that exposure, I was able to do a lot of things. So I gave up a lot of my summers, and I was a candy striper in that lovely red and white outfit. And I was, in the children's hospital every week all summer. And I knocked on the doors of my parents' PCPs, and I spent summers with them. I know in this era, it's a little bit hard to do that. So this is why you're doing this virtual shadowing to get what it feels like to do that. So once I get out of the state of Georgia, I did college in Baltimore, graduated there, and then was a very traditional student, graduated after college, went straight to medical school, in Philadelphia. And when you asked me going in what kind of doctor I was going to be, it was pediatrician. I was going to be a pediatrician. That was all that I was going to do. And then you have that last summer in medical school, and it's the summer between your first year of medical school and your second year of medical school. And I was living with a roommate who had been in EMS and being paramedic. And she said, why don't we get the emergency department? Never knew if an emergency medicine physician, didn't know anything about it, but it was a job and it was something to do over the summer. So that's what I did. So I worked in the emergency department, and I learned how to put in IVs. I learned how to do EKGs. I walked patients, transported patients to CAT scan. I, brought blankets, brought food, whatever needed to be done is what I did. And that's when I realized that this is the medicine I loved. I loved emergency medicine. I loved seeing the patients come in immediate and figuring out, this is what I need to do. This is the direction I need to go, and treat them in those first hours of their presentation. And that's what I loved. But that didn't stop me from falling in love with every other specialty when I got to do it. So this is sort of what you do. This is what I did at my medical school. I actually looked up the curriculum, and these are the rotations that I did in third year. And when I did each rotation, I loved every single one of them. I loved internal medicine because they knew everything about how the human body worked and, the medicines that affected. I loved family medicine because I got to see from birth all the way through death, and they could be your patients all along. I loved obstetrics and gynecology because I loved the OB part of it, and I loved treating women. Neurology, I loved seeing how the brain functioned and how those connections were made. Psychiatry also, there's not a rotation that I didn't love. And I quickly realized that I couldn't make that decision if I wasn't systematic about it. So I started a pros and cons list. So every time I did a rotation, I wrote down the pros of why I loved this rotation and the cons of why I didn't want to do this. And then my fourth year went in, and I was sure that I was going to be a surgeon. So I did a sub internship actually in surgery, and I spent long hours in surgery. And I realized that, and I did it during winter, and I realized that I missed the sunlight because I would go in and have to be rounding at 6 o'clock in the morning, and I'd round all day and see patients all day. And I would leave around 5, 6 o'clock. And so it was dark. So for those entire 3 months, I never saw the sun because I was in the hospital. And I realized that I couldn't do surgery. So, then I did my emergency medicine rotation, realized that this is what I loved. This is what I loved seeing. I loved the procedures of surgery. I loved seeing people from birth all the way through death. I loved the change, the different kinds of internal medicine, psychiatry, neurology. I loved it. Had everything of all the rotations I loved. And then it had what I didn't like. So I realized that I didn't like clinic. That just wasn't me. And so it had all that. And so that's how I chose emergency medicine. So, I skipped ahead to a slide. So then match day comes. So it's usually around March 15th. So match day came, and I matched. And it was actually a very interesting day for me. So I was loved that I matched emergency medicine but I cried because of where I matched. While I loved the program that I matched at, I did not want to be in the city that I matched at. So it was a two-found thing. And then everyone always asks about student loan and debt. And this is what I graduated with. So when I got out of college, I had $10,000 debt at 5% interest, and I had medical school. I had $191,000 debt at 8.25% interest. Now, I paid back a lot more than that, but that is what it started. I could not find the actual amounts I paid back, but that's where it started. So welcome to residency. Here I was, a girl from a very small island in the middle of the sea, growing up in the South, now in New York City, starting a residency, and was excited and scared, but more excited than scared. And I graduated medical school in 2001. And why that's really important is because I was an intern in New York City on September 11th, 2001. So here I was, not knowing or not feeling like I knew anything of medicine. And I was in one of the hugest disasters in most recent history. And I remember that day. And I don't know how many of you are alive or can remember that day, but I remember that day. I was in rheumatology clinic because we do different rotations, and I was learning how to do joint injections. And someone told me, a plane ran into one of the towers in World Trade Center. And we had a little prop plane that had run in one of the towers. So I just assumed that that's what it was. And then, the news finally hit how big it was. And it was frightening. We immediately all got called back from whatever clinics we were. And we got put in, I think it was either an auditorium or the cafeteria. And we were basically told that we were to expect large volumes of patients, and that we had a pager, and that we had, from the minute our pager went off until we had 30 minutes to be back in the hospital. And that was going to go on for the next, week, 3 weeks, however long it was. All vacations were canceled. All travel was canceled. If you weren't living in Manhattan, you needed to find a place to stay in Manhattan. You could not go back to your house in Jersey if that's where you happened to live. Unfortunately, those patients never came. We got through it like we always did, but then as I seemed to attract disaster, the other thing that happened was the blackout of the Northeast quarter in 2003. So this was significant, and there was one of the grids had an outage, and it caused basically most of the northeastern coast to be blacked out. It was probably the busiest night I've ever had in any emergency department because it was summer, it was hot, nobody had power, nobody had lights. We had generators running the hospital. So people were scared, and they came to the emergency department. And they were there for whatever reason there was, but they weren't leaving. They were going to stay there until the lights came on, till the sun rose in the morning, so that they could be safe. What was really cool about it is we snuck out of the ER and walked to the front of the hospital, and a bunch of the residents and a bunch of my resident friends and I talked one of the security guards, hospital police, into turning off the spotlights that were around the hospital. So we saw some stargazing in New York City. And I don't think you've probably ever been able to do that since then, but it was nice, seeing stars in New York City. So then I graduated from medical school, and I pretty soon after my graduation, I got married. So my husband and I actually went to college together. We didn't date in college. We started dating in medical school, but we did not couples match. So what couples matching is that you can decide to apply to same residencies, and the residencies will take you and try to match you up with your significant other in the same city or a nearby city. We didn't couples match because while I knew that he was probably the guy I was going to spend the rest of my life with, I wasn't going to make a decision on what program I loved based on him. So I ended up in New York City and he ended up in Dallas. So for 4 years, we did a long distance relationship, not even on the same time zone, but we made it work. And these were in the days before internet, before texting. Cell phones did exist. I'm not that old. And so we called a lot. And what was really nice about that was having somebody in medicine. It meant that when I walked in from an overnight or whatever shift I walked in, and I was tired, I could tell him about my day and he understood, and I didn't have to go into a lot of detail. But what was also nice was that when I was tired and I said, you know, babe, I just don't want to talk tonight. There was no judgment. It was an understanding of, you're just tired. Go to bed and we'll talk in the morning. So that was amazing. So graduated residency, got married, and then didn't know what we wanted to do. So he was in Dallas. He graduated a year ahead of me because he's a pediatrician and his residency ended in 3 years, and my emergency medicine residency was 4 years long. So I did what was called locum tenens, and I know Dr. Kolstad worked a little bit of locum tenens last week. So it's basically, I was a temporary physician and I traveled pretty much the United States. It was nice because he was a hospitalist. So we would try to work the same 2 weeks of the rotation, of the month, and then we would travel the 2 weeks. So if we wanted to go to the beach, I would pick a location near the beach, and then he would come out and meet me. If we wanted to go skiing, I'd pick a location near mountains, and then he'd come out and meet me. And I did this for about almost 4 years. And it was amazing. Loved it, had not a problem with it. And then we decided to have kids. It's kind of difficult to have a newborn, be a traveling physician, and hand off a newborn to a very capable pediatrician, but a newborn nonetheless. So at that point in time, I decided I could no longer do locums, and that's when I started my academic job at Parkland. With our first kid, we don't have any local family. So we live in Dallas. My family's still in Atlanta, and his family's in Philadelphia. We both were working full time. So the options were, daycare or do we get a nanny? And we chose daycare for our daughter. And so she spent time at daycare. We found one that worked with our hours. But what that meant is, because we didn't have a nanny, is that we had very detailed scheduling. So we have a very detailed schedule. So, I needed to make sure that neither of us were working nights, so that one was always home with her, or somebody was not working weekends, so that there was somebody always there with her. So there are times that we're there together, and then there are times that we're tag team parents. So after having my daughter, I work full time. I decided I really enjoyed ultrasound. So let me talk a little bit about what is ultrasound. So if you guys have ever done physics, you understand a sound wave. And so that's pretty much what it is. It's just sound. What we can hear is 20 to 20,000 hertz, but diagnostic ultrasound ratchets it up about 6 times, and then we're talking in the megahertz. So how these sound waves are generated is that there are crystals in these probes, and they get an electrical pulse. The crystals vibrate and they send out sound waves, and then they hit an organ, and then they bounce back, and then those crystals are able to vibrate again and then change it into a picture. So you can now see, okay, that looks something like a kidney. And what we really use is what's called V mode. Sound waves also are something you will see, you've known about from sonar, from bats, same sort of concept, just a little bit ratcheted up a little bit. So I decided I wanted to do an ultrasound fellowship. And what that involved is that ultrasound really has been a standard in the emergency medicine practice since 2001. So pretty soon after I graduated residency, pretty soon before I graduated residency, became standard of practice. So we did a few scans, we looked at a few organs, and we could make judgments on those organs and help patients. And then what it was is that, so an ultrasound fellowship is really studying ultrasound for that 1 year. So I go through the basics that, everybody learns in emergency medicine residency. But then I also started studying advanced ultrasound. So things that radiologists do, new techniques, new way to do it. And then I also learned how to start an ultrasound program, how to get people interested in doing ultrasound, how to recruit faculty, how to manage a program, how to buy ultrasound machines, more business of medicine. And why did I do it? So I loved ultrasound when I was a resident. And if I was going to do a fellowship when I graduated, that was the fellowship I was going to. But I was ready to not be a student anymore. So I went to the working world. And then the opportunity arose, and I said, you know what? I'm going to take it. I want to learn ultrasound. I want to be better at it. And then I want this advanced skill set. I want to know these other things. And watching the people who had done an ultrasound fellowship, they had this understanding of anatomy and physiology and all those things that you learn in medical school, and putting it together and how the human body works and how it's going to affect patients. And I wanted to be that person. So I did the fellowship. Yes.
Jody, this is Ray. Do you feel like your basic understanding of anatomy and physiology that you learned in medical school were sufficient for your understanding of ultrasound, or did you have to go further?
If I had recalled all of that anatomy and physiology, then yes, it probably would have been sufficient. And if I had become a surgeon, it probably would have, but at least the anatomy would have been sufficient. But I found that I'd forgotten a lot of it. So I had to go back and relearn a lot of that anatomy, because you don't use it all. And unfortunately, if you don't use it, you lose it. So does that answer your question?
Yes. And did you learn a three-dimensional anatomy approach when you were in medical school? I did not.
So three-dimensional in the anatomy, yes. But when you're looking at scans like x-rays or CAT scans or things like that, dimensional, then you kind of have to put it virtually together in your head to figure out what was going on. So I finished my ultrasound fellowship, and then, just wanted to add to it. So we decided to have a second child. So we were both still working full time, but now that I had graduated a fellowship, I was expected to do both clinical shifts. So I work in the emergency department, see patients, but I also had teaching responsibilities. So now I was expected to teach residents how to learn ultrasound. I was expected to teach other faculty how to do ultrasound. And this is what I loved. I loved the teaching aspect of it. But we still didn't have any local family. My parents still lived and his parents still lived on the East Coast. So once again, now we have a second kid that's in daycare, and still with the detailed schedules. But I realized that that if I was going to make this work with 2 children and teaching responsibilities, that I needed to change my schedule. So I became what was known as a nocturnist. So I only worked night shifts. So I only worked from 11 p.m. to 8 a.m. And I did that for several years. And how this worked in my life was that I could get home after my night shift, get my kids ready, get them fed or breakfast, and get them to daycare during the day. They were at daycare all day. I would sleep all day. Either myself or my husband would pick them up, and then we could make dinner, eat dinner as a family, interact with them, put them in bed, and then I could go to sleep. And then once I woke up, I would then go to my night shift and start it all over again. And I loved it. I really loved working night shifts. The downside of it is that when my daughter was in kindergarten, I asked her, what do her parents do? And so she said, oh, my dad's a doctor, but all my mom does is sleep all day, which is a little bit hurtful, but from her perspective, it was all she knew. Mom was asleep, mom would come home, get us dressed, and then go to sleep. So I had to do a little education that mom didn't sit around sleeping and eating bonbons all day. But I loved being a nocturnist. I loved, seeing patients at night, working with other night people. it was just what I loved, and it worked for me. So let me tell you just a little bit about kind of where ultrasound has come in medicine. So this life cover was from 1965, and it wasn't the original, but it was kind of the public's original introduction to ultrasound. So here's the patient. They hung a bag of water over the patient because ultrasound works great in water. And then the ultrasound probe is above the patient in the water. And then you can see this circle right here, and that is the head of a child. So this is the patient. You can see that she is pregnant, and that is the fetal head. So this is 1960. This is about 1980, 1990. These are the ultrasounds. And so there's still these kind of, several 100-pound machines with a lot of buttons and not very easy to use. And then today, this is what we use. So this is an ultrasound probe, and it connects to an iPhone. So you can put this in your pocket, and you can get almost the same information that you can get from one of these machines. So most people's introduction to ultrasound is, sorry, I just realized my videos aren't playing, is when they're pregnant. And that's usually kind of the, what most people understanding of ultrasound is. When I'm going to tell somebody I'm doing an ultrasound, they're like, especially if it's a guy, he's like, oh, are you going to find out if I'm pregnant? Is it a boy? Is it a girl? That's kind of people's most introduction to ultrasound. But there's so much more than this. So yes, you can use ultrasound to say, okay, you're pregnant, it's a boy, it's a girl, but you can use it to look at, any abnormalities that are going on with the pregnancy. And it's safe. There's no radiation involved. It's painless, and you can do it over and over again. So hold on one second. So I'm gonna delete this. Hold on, I just realized I'm gonna change one thing. I just realized, oh well, I just messed it up. So in gross anatomy, when you first introduction to sorry, I just realized how I messed this up. When you're first introduced to you can't see it. Give me a sec. Let me move that. There we go. So when you're first introduced to medicine in the human body, it's with gross anatomy, and you're dissecting a specimen. And some places have gotten difficulty with looking at cadavers, so they have these kind of fake specimens that you can look at. Some places have gone even high tech to where it's AI. So now you can do part of that on the computer, and you can peel back layers. You can look at the skin, and you can peel back layers and figure out what's going on with and how to examine the human body. So these are there. I think if I looked it up, there are a total of 72 organs in the human body. And everything you see on this screen, except for where the green arrows are, I mean the green X's are, I can ultrasound. So it's gotten so much more beyond just, are you pregnant? Is it a boy? Is it a girl? Are there any defects? I can look at liver. I can look at skin, kidneys, stomach, bones, you name it, I can look at it. So I can look at, like I said, bones, muscles, tendons, nerves, eyes, hearts, lymph nodes, joints. I can do procedures with ultrasound. And this is just what I do in emergency medicine. There's so much more in the house of medicine that can be done with ultrasound that I don't even do. So some medical schools, can I stop sharing real quick and then just redo my thing? Give me 1 second. I'm sorry, guys. I'm having some difficulties here.
Please do. If anyone has a burning question, please put it in chat. Dr. Morchetti and I and some of the team are busily answering questions. Yael Brook says, I love doing anatomy with a physics background to understand how it works. You're right. Dr. Jones, we have a question from Daniel. How useful
Okay.
is ultrasound to look at the brain, though?
So you can look at the brain in ultrasound, but usually it's used for babies. So babies are usually the one that you do ultrasounds when you're looking at the brain, because ultrasound is not amazing at looking through bone. So you have to go through the soft spot in their brain to kind of the holes before the bones fuse to look at it. But they use it in ultrasound and looking at the brain. Other questions, or keep going?
Please move right along. There was a question, is the use of ultrasound 100% safe? Is it considered radiation?
No, and I will answer that question in a little bit later. So yes, it is safe, and no, there is no radiation involved in ultrasound. So this is just a sample curriculum of where you can start with ultrasound. So you can start, medical school year 1, you can do ultrasound of the anatomy, head, neck, then you can do focused elective, and then you can do things like pediatrics and internal medicine and family medicine. But there's not a specialty yet, maybe psychiatry, that I know of that's probably the only specialty that doesn't use ultrasound. It is throughout the house of medicine. So let's just talk about some of the ways you can use ultrasound. So when you're in medical school, you're taught to look and do the eye exam. And so you know how to use a slit lamp, and you examine the eye, and you do an ophthalmoscope, and you look at the back of the eye. So what if your patient comes in like this? My ability to look at his eye is going to be severely reduced because he can't open his eye. So I can't tell you if there's an injury underneath. So this is where my ultrasound is going to come into play. So how you do it is you're going to fill the eye with gel. So ultrasound waves don't travel well through air, so I have to use a medium to see them. So I use a fluid-filled medium, so it can be water if the patient's in a water bath, or gel. And then I have my transducer here, and then I will move up and down the eye and be able to see the structures that are below. So this is what it looks like. So here is the anatomy of an eye here. And this is the ultrasound of the eye. So here's the lens here, here's this posterior chamber here, and then the optic nerve pops in. I think just a little bit over here is where the optic nerve pops in. So I can now, if you've got that guy with a really swollen face, I can look at his eye and say, okay, I can see, this is what I can see with your eye. I don't have to force your eyelid open to take a look at how it looks. And I can also look at it and have him move his eye right to left. And I can say, oh, okay, the muscles are involved. Your eye can move right to left. I can see it moving. And then I can fan through it and say, you know what? I know what happened. You have something in your eye. This is a BB that's in somebody's eye that I can then use to, call the ophthalmologist for have them come and decide what the next step of it is. So this is what's the amazing thing about ultrasound, is that I can look through skin. I have that X-ray vision to look at through skin and see the organs below. And then when you look at the eye, if you guys, I'm sure have watched any TV shows, they always shine a light in somebody's eye. And what you're looking for is the consensual light reflex. So as you shine a light here in this patient's right, you'll see the left eye will constrict. So it's the consensual light reflex. Well, for that guy whose eye is swollen, there's no way for me to pry his eye open to look at his eye. So I can ultrasound it. So then here I'm shining a light in the unaffected eye, so not in this eye. And then I can watch that pupil constrict and know that those brain mechanisms are intact, and so that people will be able to, when I'm examining his eye. We're also taught physical exam. And so when you're using physical exam, you've got to remember your anatomy to where things are. So if you're looking at the kidneys, you've got to remember, okay, the kidneys are in the lower thoracic part of the spine. They're in the closest to the back. The left kidney is a little bit higher than the right kidney because the liver is so large. So if I'm trying to figure out if someone's having kidney pain, I've got to remember this is where I'm looking for the kidneys. This is where their pain is going to be. And when you're doing gross anatomy, this is what the kidney looks like. So you dissect out the kidney and you say, okay, this is what my kidney looks like. This is the vein, this is the blood supply that leads from the kidney. The artery comes across, and this is how I drain the kidney. And then when you cut the kidney in half, now you see the inner workings of the kidney. So now I can see that urine is going to start out here. It's going to start in the Pyramids is where it's going to be filtered through the nephrons, and then those pyramids are going to start making minor calyces to make a major calyce and a renal pelvis, and then urine is going to come down here. Well, I can see all that in ultrasound. So now I can put my ultrasound beam right at the mid-axillary line, and I can point and I can look through his skin, and I can see, okay, here is his kidney. This is me. This is what I can see. This is what the kidney looks like when it's in the body. I don't have to cut him open to see what his kidney looks like. And then when I do an ultrasound of the kidney, I can fan up and down the kidney, and I can say, okay, this is the same anatomy that I saw when I did cut it open. And I can say, okay, here's the pelvis, these are the pyramids here, and then this is its relationship to the liver. So now I'm going to give you a patient example of how I use this with patients. So now I've got somebody, let's say a young gentleman comes in, and now he's having flank pain. He's got that back pain. It's where the kidneys are. But I'm concerned, are there other organs that are injured in there? Or, is this a kidney stone that he's having? So with this gentleman, I'm thinking more of a concern of a kidney stone. And kidney stones start in the kidneys, and then they pass all the way down to the bladder, and then you pee them out, basically. Sometimes they get stuck. So if a kidney stone gets stuck, then the urine is backing up and it's not able to make it into the bladder. So then you have what's called hydronephrosis. And so that middle of the kidney, which was supposed to be white, is now black because fluid on ultrasound is black. And this is what it looks like. So now I've got fluid collecting in his kidney. I don't see the stone itself, but I can say, okay, I think there's a stone there. Because now I'm seeing the backup of fluid. So why would I pick ultrasound to look at this guy's kidneys as opposed to getting a CAT scan? So it offers me real-time answers. So while the gentleman is there, I can do an ultrasound. I don't have to move him to the CAT scanner. He doesn't have to leave my department. And I can look at his anatomy, and I can look at the physiology and how things are functioning. And I can say, okay, now I see the blockage. There's no radiation involved, so I don't have to expose the patient to radiation. And it can guide my therapy. So if I do an ultrasound and I see that you have a kidney stone, I don't necessarily have to go chasing other differential diagnoses to figure out what you have. What ultrasound doesn't do is it doesn't replace the physical exam. So you still have to look at your patient. You still have to examine your patient. And it doesn't answer every question. So if his kidney is okay, then I have to now find an answer to look at other organs. It does have limitations. So ultrasound does not work well through gas. So I have to find another way of looking at those other organs.
Hey, Jody, we have a nice question that says,
yes.
Can the kidney stone, a ureteral calculus, be seen as a foreign body? Just like you saw that you had a good shot of that BB that was in that guy's eye. So can you see a kidney stone?
Yes, I can. So it depends on where they are. So if the kidney stone is in the kidney itself, then yes, I can see it. But I cannot trace it down the ureter along its way to the bladder. So if it's in the bladder or if it's in the kidney, yes, I can see the kidney stone itself. But along its path, I can't see it. I'm looking for evidence that it exists. I don't actually see the stone itself. And then one thing I forgot to mention on this slide is that the ultrasound beam is like a flashlight. It only shows where you point it. So if you are pointing it to the kidney, then I can see the kidney. If you are pointing it to a spine, I see the spine. It only shows me where you point it. I can't look at other things. And then, not what I do in medicine, because I don't do this. Now I can use ultrasound, and I can I can turn down those ultrasound beams, and I can cause what's called lithotripsy or shock waves. And now I can break up the stone that's in the kidney itself. And now it can break up into smaller stones, and then, they can pass the stone itself. So this is the first break.
Jody, what's the difference? Yeah, that slide right there. What is the difference between, I don't know what I'm asking, the
sound
type
waves?
of ultrasound beams, yes, of the sound
okay,
waves.
The frequency of the sound wave.
Lithotripsy. Yes.
So it's about 3 times less fast, lower frequency. So ultrasound is in the megahertz. I'm talking about almost 20,000 megahertz. Usually for a kidney, I'm about probably 8,000 megahertz. When I'm talking lithotripsy, I'm talking about 2,000 hertz. So it's about 3 times less fast. Questions?
Yes, a good one here is that how long does it take to learn to read ultrasound since they, Anna asked this, how long does it take to read them since they look fuzzy to me?
We teach our residents in about a month. So they come in with them agreeing that they all look fuzzy and it all looks like some shades of gray. And by the time they are done a month later, they can read and find pathology and look at anatomy quite well.
Jody, are there ultrasounds that are in color? Is that the way of the future or the now?
So there is a color aspect of ultrasound, but it's more looking at blood flow or looking at flow of liquid. So you look at blood flow as if an organ's getting perfused properly. So that's a way that you can do it, but there's not a color as in like, oh, now I can make it a shade of green or a shade of red. I can change some of it, but I change everything. I can't make an organ a different color from the surrounding tissue.
Another good question, changing the topic a tad, is who all can do an ultrasound fellowship? Is it only emergency medicine or radiology or surgery?
So at this time, there are several that do ultrasound. So radiologists know how to do them. And that is a different residency and a different fellowship than what I have done. If you're going to do a clinical ultrasound fellowship, right now it is open to anyone that wants to do it. So a family practitioner can do it, a surgeon can do it, anybody can do it. We are not one of the specialties at this moment that has board certification. So it is open to everybody. When it becomes part of a board certification, which will happen in 2021, 2022, I think it's only open to emergency medicine physicians at that time.
You think there's a way that ultrasound one day could be expanded to telemedicine?
So that is actually one of the ways that they're looking at ultrasound. So patients can be directed on how to do it. And it is used in telemedicine, not really here in the United States so much, but more in resource poor places, more across in like Africa, where a physician is doing an ultrasound and not quite sure what they're looking at. So the images get uploaded to a cloud, and then someone can look at those images in real time and tell you exactly what you're looking at. And that does happen now, and that has been happening for several years.
All right, a different question, different subject. How can you use ultrasound to diagnose COVID-19?
Can you put that question on hold? I actually have a slide for that.
You got it. Let's do.
Wait, before I get that, it doesn't diagnose COVID-19. I can show evidence of lung infection. So I can't per se say that when I'm looking at the lungs that is specifically COVID-19. I can tell you it looks like a viral infection that could be consistent with COVID-19.
Great. Any of the working group have any questions that you've picked up for Dr. Jones?
Yeah, we have a bunch of high yield questions. So one of the big ones was what was the night shift life like in the ER?
So a night shift in the ER, I like it because you come in and the ER is winding down from its busiest. So it's usually, I think, pretty busy till about 10 is when the most patients check in. So you come in with running. So you have, packed rooms, you have patients everywhere, and you see all those patients. And then you by the time you get to the end of the shift, the goal is to clear out the waiting room, to have no patients waiting by the time the morning crew comes in. And then it's a different set of patients really that come in the day and the night, you'll start to notice. So sometimes in the nighttime, you'll start to see more of your frequent flyers. You'll start to see patients that are that may be homeless and are looking for a place to stay that's warm, or maybe looking for, and not to say they don't come in the daytime, but you see a lot more of them in the nighttime. And then at night, I feel like there is a better sense of camaraderie among the staff itself, because we are all kind of in this and working through it. And so we all want to get finished. Okay, excuse me one second. Can you go find your father, please? Jason, go find your dad. I'm sorry, guys.
No
Welcome
worries.
to medicine and parenthood.
Okay, another question is, what advantages, oh, I think I'm breaking up.
I didn't hear the question.
Okay, what advantages did completing an ultrasound fellowship provide you?
So it provided me that I got to do the basics. So the basics that everybody knows, but I got to hone in and really capture like my skill and make my skill. And then I do more advanced things with ultrasound. So I do more regional blocks with ultrasound. I look more detailed at the heart with ultrasound. I teach with it. And then there's the business aspect of medicine, which is always there, that I've learned with ultrasound, is that I now know, like, you know, I look at the business of, okay, these are how many patients I have. These are how many ultrasound machines I need. This is kind of more of the business side of like purchasing and running a program.
Gotcha. And then speaking of kiddos, a lot of people wanted to know how you managed to balance life in medicine and your personal life.
The very detailed schedule, my husband probably hates it, but we are still very old school, and I have the paper calendar that hangs on the wall. And if you want to do something, it has to be on that paper calendar. So my kids, you know, lessons are on that calendar, you know, piano lessons, things like that are all on that calendar, so that we can all look at that calendar, know what the plan is for the day. And then the other thing we do is that my husband and I try to take one weekend a month where we are both home with the kids. So neither of us work all weekends. We still don't have a nanny. So we work during the week and we flip. So they do go to after school if we're working a shift. So we pick them up a little bit later after school. And then one of us is always at whatever they're doing. If one of us is always at piano or their soccer games or things like that. So he works weekend. I think if there are 5 weekends in the month, I work 2, he works 2, and then we take 1 off. If there's only 4 in the month, then we try to still get 1 off when we're home together as a family. And then we try to eat dinner together every night. So I really like the night shifts. I don't work them as much anymore. But I don't work what we have our evening shifts. So there's a 3 to 11 or a 5 to 2 shift. And I really don't work those because that gives me time with my family. So we sit down every night as a family and have dinner to try to make something normal in my kids' life.
Gotcha. And then we'll do one more question. They wanted to know, what different specialties do you work with on a regular basis? You mentioned ophthalmology, but what other ones?
So for teaching ultrasound, I work with our surgeons. I help teach our surgeons ultrasound, our family practitioners, they come through us, our internal medicine. We have pulmonary, we teach their fellows also. Anesthesiology, we work with them. I think that's all I can think of offhand that we work with ultrasound. But in the emergency department, we see all specialties. We call everybody, we get to know everybody. Dermatology, internal medicine, surgery, psychiatry, neurology, you name it, I can consult them. I have them at my fingertips in the emergency department. So I've learned to work with every specialty and realize the strengths and weaknesses of every specialty. Podiatry, I work with them all.
Awesome. Well, I think that's it for now, but we will certainly answer more later on.
All right.
Thank you.
Keep going. Mm-hmm. So I'm going to bring a little bit of kind of everything we do. So I know you guys have heard of Dr. Pimple Popper. If you haven't, She's a great show to watch. But let's bring a little bit so you guys can understand how we can use ultrasound and how it can affect your everyday. So if you have a pimple, you kind of can look at it sometimes and you go, okay, this one's ready to pop. This one maybe not so ready. But when you look at a patient, you're not quite sure sometimes. Is this ready to pop? Is this not ready to pop? And you need to make that decision. So when I'm looking at the skin, the difference between what's called cellulitis or a skin infection or an abscess, so that's a pimple that's ready to be popped, is kind of laid out here. So cellulitis, usually it's diffuse. It doesn't really have any well-defined borders. It's indurated, so the skin feels a little bit thicker. It usually is not as long, doesn't take as long to get there. And the treatment for that is antibiotics. Now, if it's become an abscess, so now it's a collection of necrotic tissue, it becomes what's called fluctuant. So it feels like you're touching a water balloon under the skin. It usually takes a little longer to become an abscess. And that is a completely different treatment. And that involves opening that wound up, so popping that pimple and draining that pus out, because that's how you fix it. So ultrasound helps me in making those decisions, because sometimes I can't always tell just by looking at somebody's skin if it's something that needs to be opened up. So if I'm looking at someone's skin and I say, oh, you know, that looks like a cellulitis, maybe it's an abscess, I can ultrasound it. And I do everything in 2 fields. So I start one way and I ultrasound over the skin one way, and then I go the other way and I ultrasound over the skin the other way. If I still have a question, the nice thing is the body has 2 sides, so I can ultrasound the same part on the body on the other side. And then if it's a cellulitis, it's known it looks like what's called cobblestoning. So between all those fat lobules, I've got fluid that collects between the fat lobules, and it really looks like cobblestoning. And this is what it looks like. So this is just a cellulitis. So this would be treated with antibiotics, and that's the fluid collection or the inflammation around those fat lobules. So there's nothing there that I would go in and drain. This is one of those pimples, if you're looking at a pimple or an abscess, that's not ready to be opened up. This is going to be treated by antibiotics. This is going to be treated by warm compresses to kind of hopefully help it heal. But when I'm looking at something that's an abscess, that is a collection of necrotic tissue. So now all that tissue has died and it's collected under the skin here. And so it's a collection of necrotic tissue. It may have a well-defined border. So it may be something that I can open up and I can see, oh, here's where I need to do it. It may have an irregular border, but this is something I need to put either a needle in, or I need to take a scalpel to someone's skin and open this up and drain this out. And then we talk about fluctuance, and I said it feels kind of like pressing on a water balloon. But the other thing you can do is you can use your ultrasound to see the fluctuance. So now I can see that necrotic tissue moving under their skin. And so as you see, as I'm pushing down, I can see it kind of squirting from side to side here. And so I can see how deep that abscess is and how much I need to cut and how much I need to get out. And then if I don't need to cut it, the other things I can use ultrasound for is fluid drainage. So if a patient has a pocket of fluid and I need to take some of that fluid out, I can put a needle in there and I can see that needle ultrasound. And I know that I'm not hitting any other organs, I'm not hitting any bowel, and I can drain some of that fluid. And then the other procedures I can do is that if people come in and they need an injection, so I need to, give an injection, drain some fluid or put some fluid in the joint itself, I can use ultrasound to direct my needle exactly where I need to go to, inject medicine into that patient's joint. So it can help just, lead me into treating the patient. And then, when you come to the hospital, most of the time we end up putting an IV in a patient. Not always are they really simple to find. Unfortunately, sometimes people have like broken an arm and they don't really have those veins that I can use. So I can use ultrasound to now look at veins that are a little bit deeper under the skin, and I can put an IV in them and I can direct therapy, because now I know exactly where I'm going and I know that I've hit the right spot. So I'm going to put you guys up for a challenge. Disease process that you guys hopefully have heard of before. Got a 20-year-old gentleman. He comes in with right-sided pain. He's not a big guy. He's got normal vital signs. He's got no pain with urination. When I press on his abdomen, he's tender in the right lower quadrant of his abdomen, so kind of right over his right hip or right near his right hip. I've ordered some labs to kind of help direct my therapy, but I'm really thinking this guy has appendicitis. And so I can think one of two ways. Do I just go ahead and call surgery and say, hey, you know what? I'm really sure this guy has an appendicitis. Why don't you come take a look at him and go ahead and take him to the operating room? Do I expose him to radiation? So do I get a CAT scan of his belly and, you know, take a look exactly what's going on in his belly and say, okay, yes, it is definitively appendicitis. You still need to take him to the operating room where he needs some antibiotics. Or, you know, while I'm waiting on his labs to come back, do I ultrasound him? Do I say, okay, well, let me see if what his appendix looks like under ultrasound and see if it looks enlarged. Does it have appendicitis criteria on ultrasound? So we're going to accept this challenge.
Hey, Jody.
Yes.
I read in the Journal of the American Medical Association a few years ago that 2 CAT scans of the abdomen, 2 CTs of the abdomen, give as much radiation to the body as if you were a mile from ground zero at Hiroshima. It's an enormous amount of radiation. So have you ever sent someone to the OR for an appendicitis without a CT, but only the ultrasound?
Yes, I have. I have sent people to the OR if they're young and otherwise healthy without even sometimes an ultrasound. It's harder to get an ultrasound of the appendix in adults, but yes, it does make my decision. So in your lifetime, the amount of radiation that is considered safe is about 1 CAT scan. So if you've got people who have chronic diseases like kidney stones or irritable bowel that may need repeat CAT scans over and over again, it starts to affect your decision-making in these patients, especially if they're young people and they want to have kids when they grow up. You know, how much radiation am I going to expose them to? Is there a different way? Is there something different I can look at that will give me the answer that I'm looking for without harming the patient?
So, Jody, we have all these young future physicians. There's 1,000 online. I know you didn't want to hear that right now on Zoom. And will they have to think about this as far as radiation exposure in the future? We see people all the time, and I know you see it all the time, that have had so many multiple ultrasounds, say of the kidneys or the abdomen and so forth. Does ultrasound present an option that would keep them from having to order what we call ionizing radiation studies like CAT scans?
Sometimes, not always. So ultrasound has limitations. It can't answer every question that you're looking for in the body. So some limitations of ultrasound are that as patients start to be obese, the ultrasound beams just can't penetrate that tissue. And so I can't answer that question. I can't see the organ of interest to tell you yes or no, that's what's going on. And then ultrasound does not work well with air. So if I'm worried about a bowel perforation, I still may have to get an X-ray for that patient rather than a CAT scan, because I'm not going to be able to tell that on ultrasound. I just can't see the bowel well enough to say that there's a perforation. So ultrasound doesn't answer every question. It can take away a lot of radiation, but it will never, I don't think radiation, until we find something different for CAT scan, is maybe that's MRIs. I don't think radiation is going to go away completely. I think some people are still going to be exposed. Additional questions?
Well, this is just tremendous, Jody. I mean, I know you still got a lot more to present, but what we really wanted to show to these young budding physicians is that these are alternatives that the advancement of technology has allowed us to see. Will there become a time when we all have a butterfly IQ, one of the small devices in our pocket, that we can flip these on to any old patient? Is that the way of the future?
It can be. It can be. I actually have a couple of questions, and I'll show you that we'll answer that a little bit in the end. So we're going to look at this guy's appendix and see if he has appendicitis. So the way to best find the appendix, because it is a powdered part of bowel, and bowel, unfortunately, most air filled, it's not fluid filled, is you ask for the patient where it hurts, and you have them point with one finger and show you where it hurts. And that's where you put your ultrasound probe. And so if I'm looking, they've drawn the nice bowel on this gentleman. So then this is cecum here, and I can see cecum coming down. And then the appendix is a blind ending pouch on the end of the cecum here. So it's mostly right here in the right lower quadrant. So, and it drapes over the iliac artery. So here's the blind ending pouch, is the appendix. And it can get infected when things get stuck in it, small stones, fluid, and it will dilate. So as things get stuck in it here, then what happens is that things aren't allowed to clear out of it. So it'll get bigger and bigger and bigger. And sometimes it pops, it perforates. So I'm looking for this blind ending pouch. As you can see, it stops right here. So a little bit about the appendix. I thought this was a kind of cute. So it's a vestigial organ. No one really kind of knows what it does, or not that I've found here. It's right in the right lower quadrant. And these are just kind of some things about the appendix. If you wanted to, DM the appendix, then that's how you can find a little bit about it. Appendix. He has an email there. And this is what the appendix looks like. So as I'm sharing here, I'm looking for this blind ending pouch, and this is the blind ending pouch that I can see. And then I want to see, so it ends over here. So then I want to turn it on its end, and this is how it looks on its end. And I'm trying to compress it because bowels should be able to compress. And as you can see, as I'm putting pressure on this patient's abdomen, this is not compressing. So this is what I'm concerned about, this patient having appendicitis. And so with that ultrasound, you can call your surgeons. You can skip the radiation in this young man, and they can take him to the whatever definitive therapy they want to do for his appendicitis. A couple other things that especially you can use ultrasound for are fractures. So I said ultrasound is not great for bone. The beams themselves just can't penetrate the bone, but I can see if there's a break in the bone. So, you're skateboarding, you fall off on the outstretched hand, and this is what your arm looks like. So this is an 18-year-old female. She fell off on her outstretched hand after school. So if I want to ultrasound, I'm going to go up and down the longitudinal aspect of the bone. So I'm going to ultrasound up and down the bone here, and I'm looking for an interruption in the cortex. So if I'm looking at the itself, you can see this line here, and that's this fracture here. And then if I'm doing an ultrasound here, you can see this is the cortex, the bright white of the bone, and then there's this interruption here. So this should continue, and it doesn't. And that tells me, okay, they've got a fracture. And so where this is really going to be useful is not maybe the diagnosis of a fracture, but when you're trying to reduce this. So when you're trying to get this fracture back into its place, rather than having to expose the patient to repeat x-rays and persistent radiation, you can ultrasound it and you say, okay, now I've got these lined up. This is where I want it to be. Or what if you're in a resource poor area and you're looking at a rib, which isn't going to need a splint, then you can, ultrasound that rib and go over that rib and say, yes, you know what, I really think that rib is broken. There's not anything I'm going to do. I'm going to give you pain, but I can tell you that rib is broken. Now, what if we've got now a young man that has fallen and he's got shoulder pain? So I'm concerned. I've said, okay, I can look at him and I can look at his clavicle and I can say, okay, the clavicle's not broken, but there's something weird about his shoulder here. It doesn't look like the other shoulder. So I can in real time ultrasound, so put the ultrasound beam on the back of his arm here and watch him turn his shoulder in and out. And I can see the joint moving. So I can see this is the humeral gland or the humerus here, and it's moving in this joint. And I can say, you know what, this shoulder is not dislocated. I've got to find something else to figure out what's going on with this guy. Or I can see if it is dislocated by not seeing that joint line up. So I can use it in real time and have patients move their arm a little and see if that joint is in or out. Another thing that ultrasound is used for is looking at the heart, and that's a really big one. And the problem with looking at the heart is that there are a couple enemies of ultrasound. So while I can look at the bone to tell if it's fractured or not, if I'm looking at something on the other side of a bone, I can't see that. The ultrasound beams just don't penetrate that. And then ultrasound doesn't go well through air. So I can't see what's on the other side of air. And if I'm looking at the heart, I'm looking in the thorax, which is really filled with, a lot of ribs, and I've got air-filled lungs that surround it. So I want to look at the heart. I've got to kind of find that perfect window. So I can place my ultrasound beam at the apex of the heart, which is down by like the left nipple for most people. And then I can look up and see the heart. And so I can see all four chambers of the heart. I can see the right side of the heart here, and I can see the left side of the heart. So this is what it looks like. So I start my ultrasound beam, they're coming from a different view, and I come really down to the left nipple, and then I'm pointing the ultrasound beam over here to his right shoulder. And I'm really at the apex of the heart, and I'm looking at the heart itself. And I may have to tilt my probe a little bit to the right or a little bit to the left, or rock it to get kind of in between those ribs to get the view that I'm looking at. So now I can say, all right, this is how the heart's beating. I can look at his right ventricle. I can look at his left ventricle. And this is what my ultrasound looks like. I can watch the blood flow through his heart. And then when you put it together with the anatomy, so now you can say, all right, here's the right ventricle, here's the left ventricle, and this is the anatomical specimen. So right ventricle, right atrium, left atrium, left ventricle. I can see the blood pumping through his heart. I can look for defects in his heart, congenital defects in his heart. I can make sure his heart, all the walls are squeezing nicely and coming together nicely. I can look at all that. And I can see if there's fluid around his heart, it's stopping his heart from functioning as well as it should. So if you have a patient that comes in kind of cold, clammy skin, their heart's kind of not beating in that normal regular rhythm, maybe their blood pressure is a little bit low, you can look and say, okay, I'm afraid that their heart's not working as well. And if you don't know this, these two charts here, you will get to know these charts very well in medical school. These are the Frank-Starling curve, and it's going to help you see how the heart functions. So if I've got somebody that their blood pressure is not working, their blood pressure is low, I want them here. I want to increase cardiac output. Do I need to give them more fluid? So do I need to increase their fluid? Or they're not where the heart's not working because if they're way over here, this is where they're functioning. Do I need to get some extra fluid off of them and then the heart can work? So it kind of helps you make that decision, like which direction do I need to go in someone whose heart is not functioning as well. And so then I can look at this heart. And so this is a heart that isn't functioning as well. So if you remember the other echo I showed you, this chamber is not decreasing as well as it should be. It's just not functioning as well. And this heart valve right here should be coming up and really slapping the septum here, and it's not functioning as well. So now you say, okay, I've got this patient that's, when I look at them, they've got lots of extra fluid on them, their blood pressure is low. How am I going to treat this patient when their heart's not functioning as well? So then I go back to my Frank-Starling curves here, and I realize that their right ventricle, their left ventricle is just not functioning well. There's not enough blood flow going to the rest of the body. So therefore their blood pressure is a little bit low. And it's this kind of never ending cycle. So because organs aren't getting perfused, now there's hypoxia, there's increased damage, there's inflammation. And because there's inflammation, now I've got more congestion, which is going to lead to more hypoxia, which is going to lead to less blood flow, which means the heart's not going to function as well. So if they're here, I can't bring them up by adding more fluids because they've already got more fluids. So now I have to go, all right, now I have to bring my pharmacology into it. Now I have to give them medications that's going to help their heart be more efficient, going to help move that blood flow more efficiently through the body. And then I can get that extra fluid off of them. All right, a couple more. So where ultrasound usually is where people hear about in medicine right after they hear about OB and that ultrasound is usually the FAST exam. And when you see the FAST exam, it's with the trauma and you've got this patient that comes in. So, they're in a car accident. They've literally wrapped their car around a tree and they come in and their heart rate is fast and they're not oxygenating well. And they're breathing fast and their blood pressure is low. And unfortunately, they're not wearing a seatbelt. So now the decision is what's going to guide my therapy? What does this patient need? Does this patient, have they lost a lot of blood and I'm not seeing it, or then they've lost it in the car? Do they have an internal organ injury and that needs to go to the operating room that needs fixed? Do they have a blood vessel that is popped open and now they're bleeding internally? So it's called the extended focus sonography in trauma. And so these are what you're looking at. You're looking at the right upper quadrant where I'm looking to see if there's fluid because it's the most dependent portion. I'm going to look at their heart. I'm going to look in their left upper quadrant, and I'm going to look in their pelvis. So when I'm looking in here, on the left of all is the normal. So this is what a normal looks like. So I'm going to give you a little orientation. So here's a kidney that we were talking about here. Here's the liver here. Now this bright white that you see here is the diaphragm, and I'm looking above the diaphragm for fluid. So here is the abnormal. So this may be our patient. So here's the liver here. Fluid is going to be black or anechoic. So here's the anechoic fluid that's collected in their abdomen. Over here. Now I have to think, do they have some source of bleeding intraperitoneal that I need to call, peritoneal bleeding that I need to call my surgeons for? But I don't stop at just that, that view. I keep looking because maybe I'll find another source. So then I can look at their heart. So this is normal again on this side. So this is the right ventricle here, the right atrium here, the left atrium here, and the left ventricle here. So now I can say, okay, I'm looking for fluid around the heart. So I'm looking for black around the heart to see, is there fluid around the heart that's stopping the heart from not beating? So like right here, I see, oh, there's a tiny fluid here. But then I also see, here's the liver here. There's fluid in their belly right here. So I found another source of bleeding that may the surgeons will need to look at when they go looking at why this patient's lost their blood pressure. And then if I look at the left side, so now I'm looking at the left side. So now I'm looking at the spleen. So here's the spleen here. This is the normal on the left side of the screen. And then this is the kidney here. And then this is the diaphragm here. So when I'm looking at this patient, the spleen here, it's got some calcifications in it. So I can see the bright white calcifications, the kidneys here. But now I don't see that black necessarily in between the spleen and the kidney. Right now that black is up here. It's above where the diaphragm is. So now they've got, fluid in their chest cavity. They have a hemothorax that I have to be concerned about. And then when I look down below, because most people don't get in a car accident laying down, so I've got to use gravity to be my friend. So here's their bladder here, so fluid-filled bladder, and I'm looking for anechoic or black fluid around the bladder around here. And then here I see it. So here's the bladder here. Now I can say, oh, look, a pocket of fluid in their belly. We need to act on this. We need to figure out where this patient is bleeding from and how we're going to move forward to help this patient. And then the part of the last one is that I can look at their lungs and say, do they have a pneumothorax? Do they have a collection of air outside the lung that's causing them not to be able to breathe? So when I look at the lung, while I can't see the lung parenchyma very well because air and ultrasound are not friends and they don't transmit through that, I can see the movement here. I can see the parietal pleura and the visceral pleura sliding along each other. And it looks marching is what it looks like. Now, if I'm looking at this one, I don't see that nice slide here. So what that tells me is that there's something collecting between that visceral and that parietal pleura. So they probably do have a pneumothorax that I need to deal with to help them breathe a little bit better. And then someone had asked about some COVID. So these are different patients in X-ray. So we're going to start with the healthy patients. So these are not progression. These are 3 different patients looking at the X-rays. If we switch to a pneumonia here, you can see the kind of collection here. You can see the pneumonia. You can see kind of how the lungs aren't as clear. In COVID, you see more of a ground glass opacity. So it's got some kind of collections here, kind of got collections here along, and that's what you see. Now, can I tell the difference between a viral pneumonia, so any other virus that may be causing it in COVID? I'm not that good. Maybe our radiologist can, but that's just not me. And then this is tuberculosis. So this is another bacterial infection where you can see the gone complexes up here. But I can look at their ultrasound. So here's a normal lung. So I've got that nice sliding of visceral and parietal. And then if I'm looking at COVID, now there's a lot of fluid because there's inflammation, and inflammation brings fluid. So now the ultrasound beam is able to go through that lung a lot better. So now I can see these lines going all the way to the bottom.
Jody, we lost you for a moment. Are you still with us?
It looks like kind of like I've got the consolidation. I can see a lung quite nicely. So this is what a regular pneumonia looks like. So when I'm looking at the lung in COVID, I can say, okay, you have a regular pneumonia, you may have a COVID. I can't tell you if it's COVID or another one, but that's what you have. So where is the future kind of going with medicine and ultrasound? And I don't know, I don't have an exact question for where it is. I think ultrasound will become more widespread use. We now have ultrasounds that connect to our phones. So, any physician can buy them, carry around in their pocket, and then they can use it to, look at organs, look at the anatomy, check out the physiology of a patient, and then direct care. What's my next step? So previously, it was our stethoscope. We listened to the patient. When you listen to the patient, you now hear, rather than regular heartbeat, you sounded this extra whoosh in their house, and that's concerning. You're concerned when you listen to them. You get an EKG that doesn't look quite right. And now I can do that ultrasound and I can look at their heart and I can say, oh, you know what? This valve isn't opening and closing as well as it should be. So this is what the anatomy looks like that goes along with the sound. So maybe one day all of this will be in this little stethoscope. Maybe we'll all carry that in our pockets. I don't know. You guys are the future of medicine. You'll be able to tell us where we're going to go in the future. Questions?
Yeah, so Jody, could you go back to that previous slide? That was excellent.
Here, I'll start it over again for you.
To all the nearly 1,000 people that are still on the line here, we're as always, we're so glad to have you. We hope that what you're seeing here is the future. Go ahead and show the EKG and the ultrasound too, Jody. Yeah, just like that. What Jody just said is something very important. I entered medicine in 1973. I saw one of the first brain scans in 1974. The only purpose of ultrasound in 74 was to try to bounce beams off the falx cerebri to try to look for midline shift. Fast forward almost a half century, and what you saw tonight was Jody imaging organs to look for function, fluid, abnormalities, congenital stuff, and so forth. What Dr. Jones just did with this slide here is to say the stethoscope, that I have one just like that in my pocket, the electrocardiogram, which was invented by Wilhelm Einthoven in 1893, for which he won the Nobel Prize in 1924, and the ultrasound of today that Dr. Jones was demonstrating as what she was taking, that someday that this may be combined all into
What are we going to
one.
order next?
And let's get everybody to mute, please. And they may be combined all into one. The future is, we use the term artificial intelligence. It isn't artificial, it's assisted intelligence, to be able to combine these things and allow us to have superior analytic and decision-making tools for the future. Because it is, after all, what is wrong, and then what do we do about it? So Jody, how long before we have the Stetha EKG ultrasound scope in our pocket? 5 years, 10 years, 20? What do you think?
Probably close to 5. I've actually seen the one of the first iterations of it.
And what
where
was
they
that?
can combine. It basically looks like a stethoscope with a small ultrasound bell. So you can see now the EKG. The EKG actually comes along the bottom of the ultrasound.
And so hypothetically, could there be an assisted intelligence software built into that that is able to then give us a differential diagnosis? We covered differentials in our third session.
Yeah.
You think so?
I mean, there's assisted, there are ultrasounds I didn't show you, but I showed you when you looked at the lungs, you can saw those lines coming all the way down with the viral pneumonia. There are ultrasound machines that will count those lines for you and tell you how many there are per lung field, and so it can quantify almost the fluid. There are ultrasounds that look at blood vessels and can tell you the volume of blood flowing through that blood vessel just by looking at the blood vessel itself, and that can quantify. There are ultrasounds that can tell you how much urine is in your bladder.
One of the questions that came up a little while ago, Jody, was Can physician assistants use ultrasound?
Yes.
That was a
Yes.
short answer.
I mean, so there are, I just taught an ultrasound course, and there was a physician assistant that worked in the ICU. He had one in his pocket, and he was teaching, I showed you how to drain fluid. He was teaching the medical students how to mark out where the fluid was so that they could see, so that they could drain. I don't want to say any help, because some of the equipment right now need a license to buy. So I don't know if nurses per se, I'm not saying they can't, I just don't know if nurses can buy them, but physician assistants, I'm sure advanced nurse practitioners can buy them. But you just need some sort of license. So medical license that says you can practice medicine, then you can buy these and hook them up to your phone.
Jody, nurses regularly do a bladder scan to tell us how much urine's in their bladder. What is that technology?
That is sort of the same technology I was talking. So they just place it there. They look at an ultrasound, and it calculates the volume of the bladder by taking measurements of the bladder. So it calculates, it looks like a bladder is almost the size of a cone. So it looks at the cone, and then it uses I think it's pi r, 1/3 pi r cubed is about the formula that it uses to calculate the volume.
So in this setting, you have a healthcare professional, namely an emergency nurse in our setting, who takes a technology that has assisted intelligence built in, so that the nurse themselves do not have to interpret the image, but rather the machine does it for them.
Correct. And our nurses use our ultrasounds to put in IVs. So we teach our nurses how to do IVs under ultrasound. So they do IVs under ultrasound. So I think, like I said, I think it's going to be more widespread use. It's not just going to be physicians. It's not just physicians at this point in time. But not anybody can buy one. You have to have a license, but you can.
Jody, why in the world would they have to use an ultrasound to start an IV? Can't you just see the vein and put a needle in it?
So not always. So sometimes patients come in and they have been stuck 1,000 times. They're unfortunately very sick and been in the hospital. And so those superficial veins, those ones that are right near the skin surface, are sclerotic. You can't find them, you can't see them. And then unfortunately, as our patient population just gets larger, there's more subcutaneous tissue, and you can't necessarily find or feel those vessels. So now you're going for vessels that are a little bit deeper. And then sometimes we need to access the central line. So we need those big vessels in the leg, big vessels in the chest that we can access. And so those you can't necessarily see, and that you can use ultrasound to access those.
Jody, at our conference on Thursday, Stephen Field, which for the group is one of our ultrasonographer masters, was demonstrating the use of ultrasound for endotracheal intubation to put a tube into the throat. Could you comment about that?
Yeah, so I didn't put that video in here, but yes, you can, so if you intubate somebody, you take over someone's breathing, someone's airway, you see if you have placed the tube in the right place, so you can use it for verification. Okay, yes, I'm in the trachea, or no, I'm beside the trachea, I'm not exactly where I need to be. So yeah, you can use it for procedure. Like I said, there's 1,000 procedures. And what I have told you guys on ultrasound is not everything that can be done in ultrasound. I can't cover everything that we teach our residents or that we teach the other faculty. This is just a snippet of things that you probably have heard that I thought you'd be interested in. So this is not the limitation of ultrasound. There is no limit right now on what you can do with ultrasound.
Jody, if I hear you correctly, does ultrasound also bring a safety factor? For example, if you want to start large central vascular lines on the chest, does ultrasound improve safety and accuracy on that procedure?
It does, because you know where you're going. So you can see exactly where you're going. You can make sure you're not hitting any of the surrounding tissues, or you're not going through the vessel itself, that you're not hitting an artery when you're trying to hit a vein. So it does add an additional safety, and it has become the standard of care for certain central lines or certain large vessel lines that you have to use ultrasound when you're doing them, so that you're making sure that you're not causing a complication to the patient.
Changing subjects a little bit. Let's say you have someone come in shock, and you pop the ultrasound on their belly to look at their inferior vena cava. what the vena cava, as I think many on the call, on the Zoom session know, brings blood back from the lower half of the body to the heart. And normally when you inhale, the inferior vena cava collapses. Let me ask everybody to please mute themselves. And so if someone comes in and they seem to be in shock, why would you look at the vena cava in the belly? What would that tell you?
So it goes back kind of that cardiogenic shock patient. So patients in shock. So shock is a lack of oxygenation to the tissues itself. So you want to look at, when you look at the inferior vena cava and someone's got a low blood pressure for whatever reason that may be, and their tissues are not getting properly oxygenated, you want to say, is it that they don't have enough volume on board? So do they need blood? Do they need fluid to get more volume so we can get more oxygen out to the tissues itself? Or is it that, you know, the heart isn't as functioning as well as it should be functioning, and so now I've got to help the heart pump better? And so when I look at the inferior vena cava, that'll help tell me, okay, if it's collapsing a great deal, maybe they need more volume. Maybe I need to put more volume in them and give them blood, fluids, whatever that may be, to get their blood pressure better, to get their tissue oxygenation better. But if their vena cava is really fat and it's not moving and it's not collapsing or distending, collapsing as it should be, maybe they've got plenty of fluid on. Now I've just got to help the heart push that fluid forward. So now the tissues are getting enough.
So just visualize this. You have a 25-year-old woman who's on birth control pills, who's had a very sore right calf.
You froze. I can't hear you.
I mean, she's in shock and tachycardic. And can you hear me okay?
I can hear you now.
Okay, I'm sorry. So she is having chest pain. She is in shock. You know, she has a swollen calf. She's on birth control pills. And she's in shock and tachycardic, and you pop an ultrasound and you see a very distended inferior vena cava that's not moving when she inhales. What could that be?
So looking at now is you're concerned that she's got a blood clot that has gone to her lungs. So now the heart is trying to pump as much as it can, get the blood flow out of the heart and into the lungs to get oxygenated, but it's pumping against a fixed clot. So there's no that blood to go. So that's why your IVC is distended, because it's not moving forward into the lungs. So you got to move that blockage, i.e. that blood clot that's in her lungs, to help her get oxygenated and for those organs to get oxygenated.
You mean you could have a blood clot so big down in the leg that if it broke loose, that it could go up to the heart and actually block the blood flow of blood through the heart?
You can have blood clots that go that large, and unfortunately sometimes they impede the function for the heart to work, and some people will die. They get that large. Yeah, you can have very small ones that'll just cause, you know, little parts of the lung to die, but you can have ones that are so big that have stopped the ability for blood to go forward from the heart into the lungs.
Can you tell the difference between a blood clot in the heart and actually blood in the heart?
Yes, I can tell a blood difference. So blood in the heart is going to look black or anechoic. A blood clot is now formed, so it's going to have echogenicities to it. So let me see if I can see this. So you now see how this is kind of a different shade of gray from this shade of black over here. A blood clot, more of like a shade of gray here. And sometimes you can see the blood clot moving around in their heart. And so that's not the one that's causing trouble. The one that's in their heart is not the one that's causing trouble. It's the one that's already moved from their heart into their lungs. That's the one that's causing trouble. The one that's in the heart is just going to cause problems further downstream.
So Jody, I guess my last question, and what a great session this is. This is just tremendous. Will there be future technologies, for example, portable MRI, something quantum physics based? Is there some technology that you see on the horizon? For example, a portable MRI. I know that there was some work done in Ireland a while back, that there was a helmet to put on your head to be able to diagnose acute hemorrhagic strokes or blood clots in the head. Do you see future technology coming?
So you were talking about the portable MRI. They actually do have one of those, and it probably will make it to market. I don't think it's got FDA approved, but it'll probably make it to market pretty soon, where it's for the brain itself, and you put a sleeve over the patient's head so that you can hold them still and can see that. And it's portable. It's about the size of a box, maybe an Amazon box, and you can get great MRI pictures. I saw that this past October. So, I mean, if you can dream it, it can be made. It is honestly the answer. Things get smaller, pictures get better. If you can dream it, it can be made.
That's just wonderful. You know, this is a terrific session. Reagan, did you have some questions from the group, from our audience?
Yes, I have a few. So somebody wanted to know, does everyone in medical school learn the basics of reading ultrasounds?
I wish is the short answer. It's all medical school dependent. Ultrasound was first introduced into the medical school curriculum probably, I think, early 2000s is probably where it was introduced into actually probably late 2000s, maybe like 2010, it was introduced into the medical school curriculum. So not all medical schools teach ultrasound in the undergraduate medical education curriculum. Some are very forward. So UC Davis actually gives, I showed you that picture of that portable ultrasound machine that you hook up to your phone. UC Davis actually has a grant and gives every entering medical school one of those ultrasound devices that they can use through their 4 years. And I think they get to keep it at the end of medical school, in all honesty. So it really is medical school dependent. Some medical schools don't teach it. Some medical schools do teach it. I think especially it's probably become the standard of norm in probably the next 5 years. It's going to be the norm that everyone's going to learn it.
Gotcha. And then they wanted to know, what is the difference between ultrasound and sonography?
They mean the same thing.
And then
Already, I said ultrasound's the noun, sonography is the verb.
I'm sorry. I make ultrasound into lots of verbs and into adjectives and adverbs. So, but
I can't keep my adverbs and adjectives straight. So would you stop it?
And then they wanted to know, what is one of the most interesting cases that you've seen?
Oh, in ultrasound or in medicine?
Probably related to ultrasound.
I think probably the most interesting one I saw was we saw a gentleman, and this wasn't my case, but it wasn't, who had come in and he gave the classic history that Dr. Fowler told you about. He had had previous surgery and he'd come in and he was short of breath and his blood pressure was a little bit low. And we did an ultrasound on him and we could see the blood clot from his left atrium into his left ventricle, and it looked like a worm, like almost that appendix, and it would just go and it'd squirt back and forth and back and forth. But we could also see evidence that he'd already thrown blood clots. And based on our ultrasound, we didn't get the CAT scan. We got him to surgery to get the treatment that he needed. So he didn't get further radiation. Our surgeons were very impressed with our ultrasound and they moved on and got him exactly what he needed.
Cool.
So you're saying, Jody, that with your skill in ultrasound as an emergency physician whose mind is prepared for critical care assessment, that you played an interim, a middle role between the arrival of the patient and the patient actually going to the OR. You were very specifically in the middle and helped prepare the assessment and the preparation of that patient for surgery.
Yeah. So, and I wish to say that it was my Ultrasound Fellowship that caused this, but it's actually one of our medical residents that, our emergency medicine residents that caught this. She was a third-year resident and was about to graduate, and I was her attending, and she was like, "Oh, you're going to make me do an ultrasound, are you?" And so she went ahead and did the ultrasound, and it answered our question right there. And so we were able to save this guy hours and radiation, and he got the therapy he needed very quickly because we can make that decision, do that ultrasound, and get him where he needed to be.
Reagan?
One more question, and it is very high yield. Lots of people wanted to hear this. So what is the best piece of advice you got as a pre-med or advice you would give pre-meds right now?
What was the best piece of advice that I got as a pre-med? What would I give? Okay.
I would start with get some rest.
So it has little to do and a lot to do with medicine, and more what had to do with life. Do what makes you happy, because no matter what you do, it is a job. So while I say medicine is my calling and I love doing it every day, there are days that I wake up and the last thing I want to do is get dressed and go to work. But because I love what I do, I can get up and get dressed and do that. So don't chase a specialty because you think it's prestigious. Don't chase a specialty because you're going to make a ton of money. You need to chase and you need to go into what's going to make you smile every day. Because as physicians, we will burn out. And if you look at our burnout rates, we do burn out. Medicine does get to us. But if you love what you do, you can make it past that and you can come back and you can be a better physician for it.
Cross paths with Jody twice this weekend. Reagan, can you hear me okay? I'm getting an unstable thing.
Yeah, I can hear you fine.
Okay, so sorry. Having crossed paths with Jody on 2 very busy nights in the emergency department, and Brandon, please unmute and speak up also. Somebody asked a question a while ago, what was it that I really enjoyed in medical school? And I answered, it was the science. After medical school, it's the continuing pursuit of science, and it's the people with whom I work. My friends in the world are the people that I work with in that busy emergency department there at Parkland. It's really important, as Jody was saying, that you do what makes you happy. And what makes me happy, as I did all weekend long chasing COVID, was to be around people that really love their work. They're focused, they're intense, they enjoy it, but they don't use the pronoun I very much. They use the pronoun we, that we as a team and we as friends. And that's really important. It sounds corny now, but it's the absolute truth. And that's what keeps me coming back. Brendan, you're 40ish. Are you there?
Yeah, I'm here. No, ditto on everything that you said. Plus the money's not too shabby either. But no, I enjoy hanging out with my colleagues. The thing about the ER, you work shoulder to shoulder with your colleagues. If I have a puzzling case, I can just walk down the hallway, as I did one day last week, to ask Dr. Fowler about an EKG that I had. With fellowship training specifically, like Dr. Jones mentioned, I said before, it should be your passion. It should be something that motivates you. The ironic thing is most of us, by doing a fellowship and this subspecialty training, we're actually making less money than we could if we just went and worked all of our shifts. But this is what gets us out of bed. It's what keeps us excited to get up and take care of patients. For me, that keeps me motivated. I know Dr. Jones probably the same. And by the way, having been one of Dr. Jones' former interns, I can vouch for if anyone can be taught how to do ultrasound in 1 month, if I learned it, then there's hope for every one of you.
And Brandon, what would you say now? I mean, we crossed paths a couple of times this weekend and you were in critical care. What do you feel is ultrasound in your use? I mean, Jody's a master, I'm an amateur, but you're right in the middle there. How do you use ultrasound most commonly in your work?
I use it a lot of times for the critical patient that's coming in that I need a quick answer right now of what the cause is. The hypotensive patient, the altered patient, septic patient. I'm putting a probe on them and I'm looking at heart, their inferior vena cava. I'm looking at their abdominal aorta, looking at their lungs, a lot of different areas where the answer may be, because I don't have time to send them to a CAT scan, and they'd probably die in the CAT scan anyway. And so I use the ultrasound at bedside for critical, timely diagnoses all the time.
And would you say from the time that you were in med school until now, that your knowledge of 3- and 4-dimensional anatomy, the space and time, these organs are actually moving, would you say that your knowledge of anatomy and physiology has increased during your practice?
Oh yeah, absolutely. It's applied anatomy at its best.
Well, that's wonderful. Well, I think Jody probably has dropped off. Reagan,
No,
was
I'm
there
here.
another? Are you back? Oh, you're here. Okay. I thought we lost you for a moment. Jody, we've been going an hour and 45 minutes. Would you have ever dreamed it? We still have over 900 folks that are listening to your every word.
Again,
Send a message to the pre-med students. Give them hope. Tell them what's out there, and tell them why they should look forward to it.
you know, it's the best decision I've ever made going into medicine. I heard Mercedes talk, and he talks about, you know, we all want to go in and we want to help somebody. But the way I look at emergency medicine, why I chose it, is that when I see somebody in the emergency department, I am seeing them at the worst day of their life. Nobody wants to come to the emergency department and see me. I'm happy to see me, and I love seeing you guys at work, but nobody wants to come to the emergency department and see me. They're coming to see me because they don't feel like they have any place else to go. So they want answers. They want to know what's going on with them. And I'm there in the middle of the night, in the middle of the day, in the middle of the evening to offer them answers and let them know this is what's going on. You may be okay or you may not be okay, but I'm going to be honest with you. And I'm going to take the time to teach you and educate you on your disease process.
So Jody, are you burned out and cynical? And if so, why? And if not, why?
You probably should have asked me not in the day of COVID. I was not burned out and cynical pre-COVID, but in these days of COVID and these days of quarantine with 2 children, I'm a little bit of a shorter fuse. Work is the easy part of my life. Going to work is great. I love my kids, but at work, people listen to me. People don't argue with me about why I should put on pants that day. So it's actually work is the easy part. The hard part of life is, especially in COVID, is, you know, homeschooling kids and, you know, virtually teaching kids and getting their schoolwork done, and then keeping their lives normal, like going to the park and going swimming and things like that. The rest of the world that still moves in this quarantine life.
Jody, different question. Do you feel like as a woman, you've had more challenges in medicine? I mean, obviously childbearing is part of it, but is it harder for a woman in medicine, do you think? Or is it the same or better? What do you think?
Well, I've never been a man, so I can't answer from that perspective. But as being a woman of color and being a woman, it is immensely harder. I will sit by a resident and, you know, and let's say if I was sitting beside Mercedes, I can promise you if somebody doesn't know me, they're going to start speaking to Mercedes, even if it's my patient. They're not going to assume that I know the patient. I look really young, and so I walk into the room and people naturally assume that I don't have the position that I have. Or, you know, I walk into the room and I'll say I'm doctor, and they'll say, yes, miss. And I always introduce myself as doctor. People make assumptions about me because of the color of my skin and because of my sex, of what position I have. So it hurts. And in my younger days, I was a little more mouthy and talked back a little. And then I realized that I fix it for that one person, and I hope to fix it for the next person, but it is what it is. And so I move on and I treat each patient with respect and hopefully, you know, fix the problem then so that the next person will run into the same problem.
Jody, you were one of the pioneers in our now very large department. We have over 110 faculty in our Department of Emergency Medicine, but you were one of the first persons of color, women of color in our department. And it's such a very, very important statement that it is not you, it is not I, it is always we. Have you felt challenges, though, as a person of color in terms of getting into medicine or getting into medical school, or something that I would, as an old white guy, I just simply wouldn't know? But could you share that?
So I got in the first time, so I don't know when I applied to medical school. I chose my medical school for a simple reason, and it sounds really stupid, but when I was on tour and I was viewing the medical school, people smiled. So I thought medical school was going to be the worst 4 years of my life. And so when people were, well, at least they're happy about it, so I want to go here. So I got into medical school, and then a lot of my schools had programs, summer programs that were helping people of color. So we went, and I went and spent, I think a month before med school started, and kind of got to know the programs. And then there were additional things kind of helping me as a person of color to get to know other people of color, because I wish I had gone to a school where I wasn't in the minority, but pretty much every school I went to, I was in the minority. You just kind of got used to being in the minority, and, you know, whatever assumptions people make about me are their assumptions. I can't fix your assumptions. I can educate you, but they're your assumptions. And so I tried to treat people with respect and work my way through. I also have a really amazing and supportive family. So like I said, neither of my parents are involved in medicine. But, you know, I could ask, I don't cook. So that's another secret. Guess it's not a secret, but I don't cook. And so when I told my mom when we were in high school, I said, I'm never going to learn to cook. I'm either going to marry a man that can, or I'm going to hire somebody. And so when we got married, my mom was like, you weren't kidding, because my husband does all the cooking. So it's just, you know, I find what works with me, and I try to educate people along the way, and I try to fix the assumptions that they have.
To all the folks online, still over 900 people who've been with us. We had over, I don't know what it was. Cheyenne, are you there? How many were on YouTube Live? Somebody speak up if you can get that number. Huh?
We had about 319 at the peak.
On YouTube Live?
Yes, on YouTube.
So Jody, we had 1,000 on Zoom. We had over 1,300 people listening to your wonderful talk. Ladies and gentlemen, please do a shout out on chat to Dr. Jody Jones. Tell her how much you love her. She took time out of her amazingly busy schedule. Jody, the chat is pouring in by the hundreds right now.
So I'm reading some of it. Somebody wanted to know what medical school I went to. I went to Temple University in Philadelphia, so I'm an owl.
Let everybody know that the exam, few minutes, Jody, the thank yous are still pouring in. It's difficult to express the appreciation that the working group of virtual shadowing and all of these 1,300 people who got to hear you tonight. It was an honor. Your talent, your gift, your love for your fellow people. It's just so much there that we just distinctly appreciate it. To all those out in virtual shadowing land, we appreciate you joining us. The exam questions will be online soon. Thank you to Jody, Dr. Marchetti. Thank you as always for being the wise out on our shoulders, and to the working group, we just thank you for your amazing work. We will see you back in a week, and we will be here with a physician assistant program in a week to share with you. Thank you again, and we all wish you a good evening.
And thank you guys for sitting through this.
Thank you, Jody. And
thank you.
Thank you.
Thank you.
Thank you.
Thank you. This is awesome.
Yes, yes.
Thank you.
Thank you.
Thank you, and best to you. Take care of those kiddos.
God bless.
Thank you.
Thanks.
Safe and stay healthy.
Thank you.
So inspiring.
Thank you.
Thank you.
Thank you. Thank you. Thank you.
Amazing. Thank you so much.
Thank you.
Thank you.
Thank you.
How do we take the test?
So for the exam, it's going to be a little bit later. It's going to be uploaded either later tonight or tomorrow morning. So we will have that information ready for you guys. We'll have it on our website at virtualshadowing.com. we will post it in the group me so that y'all can have it there. And then we'll also post it on our Instagram. So that is how you can access the quiz at the end.
We'll also email it tomorrow. So check your spam/promotions folder for the email. If you cannot find the email by the end of the day tomorrow, please message any of our working group for that. But please first check your spam and promotions folder. It might be there.
You can also search welcome or virtual shadowing too. That might also help.
I would search probably session number 9, links plus announcements, because that's what we're probably going to list it as.
Cool.
Or virtual shadowing. That helps too.
Cool. Okay, well, that is it. Thanks, everyone.